So today we will be discussing about hypertension. Hypertension is basically high blood pressure. You'll be surprised that in BMJ, this article was published regarding hypertension when it was first discovered in way back in 1931. And what it quoted was the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. This is history, 1931, more than a century ago. And we have come a long way about knowing what hypertension is and how it can be a major silent killer. I'll be discussing in my talk about what is hypertension, the definition of hypertension, various stages, isolated systolic hypertension, types of hypertension, the epidemiology, symptoms, complications, investigations, and treatment. So basically, hypertension or high blood pressure was previously just primary hypertension, was basically called essential hypertension or idiopathic hypertension or primary hypertension, as in contrast to secondary hypertension. Now, why it was called essential hypertension? It was called essential hypertension because it was thought that the blood pressure essentially rises with age. I'll come to that subsequently. But you should remember that after the age of 18 years, people who are more than 18 years of age, the cutoff for defining hypertension is the same. The definition of hypertension, the cutoff levels of defining hypertension have changed over a period of few decades. When I was an undergraduate student, blood pressure, hypertension in Davidson textbook of medicine was defined as any blood pressure more than 165 by 160 by 95. Subsequently, it came down to 140 by 90. And now hypertension is defined as any blood pressure, systolic blood pressure more than or equal to 30 and or diastolic blood pressure more than 80 millimeters of mercury. So why these cutoff levels have come down? This is because of number of field epidemiological studies have actually shown that at this level, the benefits of treatment outweigh the risks of hypertension. And therefore, it is important to initiate therapy and treatment and define hypertension accordingly. So things have changed quite a lot since the last few decades. What is ideal or optimum blood pressure? Ideal or optimal blood pressure is about 120 by 80. In fact, the most ideal blood pressure is 115 or 115 by 75. And with each increment of 20 millimeters of systolic and 10 millimeters of diastolic blood pressure, there is doubling of the risk of developing a heart attack or a paralytic stroke. So does the blood pressure rise with age? And this is just what I was telling previously. The rise of blood pressure which occurs in age is predominantly seen in urban population. It is much less in rural population. And the rise of blood pressure with aging is in fact not seen in primitive uncultured societies. Like if you take the blood pressures in Adivasis living in Gadchiroli, or the Pima Indians in the US, or the Australian Aborigines who have a very primitive lifestyle, who do not eat salt, the blood pressure does not rise with age. Hence, the rise of blood pressure, which is very common phenomenon in our population, is essentially driven by lifestyle changes. It is neither physiological and nor is it an inevitable consequence of aging. Which means that, and hence we have only one cutoff level of hypertension, which is more than 130 by 80 now. Now, what is the most common symptom of hypertension? Now, if you ask medical students and doctors what is the most common symptom, they will say headache, vertigo. But you should remember that hypertension is essentially an asymptomatic disease. Unless and until the patient has a very severe hypertension, patients do not have any symptoms. And therefore, and the high blood pressure hypertension continues to damage the blood vessels. And therefore, hypertension is called a silent killer. And because there are no symptoms caused by hypertension, non-compliance with therapy, either drug therapy or lifestyle measures, is very common. For example, if you have a headache, you remember that you need to take medicines to relieve that headache. But because hypertension is essentially asymptomatic, you patients forget to take their medications. And non-compliance, therefore, is a major issue. And in patients, when we see patients of hypertension, if a patient is detected to be hypertensive and he is started on antihypertensive medications and asked to do lifestyle modification, many of the patients discontinue their medications after a few months because basically it is an asymptomatic disease. And once we start medications, some of the medications may have some side effects. And also lifestyle medication is very difficult to adopt. And patients do not like to exercise, do not like to take healthy food because it is not so tasty. And because of this, non-compliance with therapy is one of the major problems when we manage patients of hypertension. Once a patient is diagnosed, you can frighten the patient by telling that he might develop a heart attack or a paralytic stroke if he does not take medications to reduce his blood pressure to normal. Patient may listen to you for a few months, but subsequently, because of the side effects and because of he is asymptomatic, patients will say that he was better off before he went to the doctor, and the doctor has started some medications for which I had no complaints. And these medicines are expensive, and these medications are causing some side effects, and these medications have to be taken lifelong. So many patients not afford to take these medications, and therefore non-compliance with therapy is a major issue. And hence, if you do a community survey of 80% of hypertensives are uncontrolled. Which is important, systolic blood pressure or diastolic blood pressure? When I was a student, the classification of severity of hypertension was based on systolic blood pressure, on diastolic blood pressure only. And subsequently, it has been found that in number of trials that systolic blood pressure is very important predictor of morbidity and mortality during complications of hypertension, and therefore both are important. But people who are more than 50 years of age, systolic blood pressure in fact is a more important predictor of cardiovascular morbidity and mortality than diastolic blood pressure. And below the age of 50, it is the diastolic blood pressure which is more important. And as I've said, beginning from 115 to 75 millimeters of mercury, the cardiovascular risk, that means the risk of developing a heart attack or a paralytic stroke, actually doubles with each increment of 20 millimeters of systolic blood pressure and 10 millimeters of diastolic blood pressure. And those who are normotensive at the age of 55 years have a 80% lifetime risk of developing hypertension. Therefore, hypertension is very common and one of the most common conditions which a clinician encounters during his clinical practice. The last few decades, India witnessed an escalating and accelerating epidemic of hypertension, diabetes, heart attacks, and paralytic strokes in India, and majority of which is lifestyle driven. It has been said that majority of these diseases of hypertension, diabetes are preventable, and heart attacks are totally preventable and they are precipitated by unhealthy lifestyle. Our lifestyle has changed in the last few decades. We have been consuming a lot of diet. There is a nutrition transition, a diet consisting of high fat, high calorie, our diet which is less intake of fruits and vegetables and fiber, and we have stopped exercising. Sedentary lifestyle has occurred, and all this predisposed to development of obesity, high blood pressure, diabetes, and dyslipidemia, which causes heart attacks and paralytic strokes. In fact, because of urbanization, overpowering globalization, consumption of an atherogenic and thrombogenic diet rich in fats and low in carbohydrate, low in fruits and vegetables, excessive use of inexpensive tobacco, lack of physical activity, leading to obesity, increased has caused an increased prevalence of hypertension in the last few decades in India. So, what is the definition and what are the stages of hypertension? Now, this is an older classification, JNC 7, that is Joint National Committee in the US, and also JNC 8. In fact, they defined hypertension, normal or ideal blood pressure, as less than 120 systolic and a diastolic less than 80 millimeters of hypertension. And they defined stage 1 hypertension as systolic blood pressure between 140 to 159 and diastolic blood pressure between 90 to 99. Pre-hypertension was before, between normal and stage 1 hypertension. That means the blood pressure between 120 to 139 and diastolic between 80 to 89 was considered as pre-hypertension. Stage 2 hypertension is when the systolic blood pressure is more than 160 millimeters and or the diastolic blood pressure is more than 100. Now, this was an older JNC 7 classification. Subsequently, the American Heart Association and the American College of Cardiology came with revised this definition and cutoff levels in 2017. And accordingly, now the term pre-hypertension has been replaced by elevated blood pressure. So the normal blood pressure is the same as was in JNC 7, that is less than 120 and less systolic and or less than 80 millimeters of mercury is normal blood pressure. But elevated is between 120 to 129 and diastolic less than 90 is called elevated high blood pressure. Elevated blood pressure. High blood pressure or stage 1 hypertension is when the systolic blood pressure is between 130 to 139 or 80 to 89 millimeters of diastolic blood pressure. And stage 2 is when the blood pressure is 140 or more systolic and or the diastolic blood pressure is more than 90 millimeters. So 140 by 90, if it is more than that, that means this patient already has gone into stage 2 of hypertension. Hypertensive crisis is when the systolic blood pressure is more than 180 and or the diastolic blood pressure is more than 120 millimeters of mercury. So these changes has occurred. The term pre-hypertension has been dropped instead of elevated blood pressure, and these are the different cutoff levels which are now used for categories for categorizing the stages of hypertension. This is the same. There's also a term called isolated systolic hypertension, and number of studies have actually shown that isolated systolic hypertension is also quite common, especially in the elderly people, because of arteriosclerosis. And patient's diastolic blood pressure is normal, but the systolic blood pressure is only elevated, or very commonly seen in elderly people. It is defined as systolic blood pressure more than 130 millimeters of mercury and a diastolic blood pressure is less than 80 millimeters of mercury. Stage 1 is when the systolic blood pressure is between 130 to 139 and the diastolic blood pressure is less than 80 millimeters of mercury. Stage 2 of isolated systolic hypertension is when the systolic blood pressure is more than 139 and diastolic blood pressure is less than 80 millimeters of mercury. Basically, in isolated systolic hypertension, there is only elevation of systolic blood pressure, whereas the diastolic blood pressure remains normal. There is also a term called accelerated hypertension, in which there is a severe increase in blood pressure to more than 180 or 120 and associated with target organ damage which occurs because of high blood pressure, with the signs like the signs of retinal hemorrhage and or papilledema. Papilledema is basically swelling of the optic discs. So, and There is a term called malignant hypertension, where usually the systolic blood pressure is more than 200 millimeters of mercury, and the diastolic blood pressure is more than 140 millimeters of mercury. It is associated with papilledema. Then in that situation, it is called malignant hypertension. These are conditions where patient should be treated immediately. Now, what are the types of hypertension? Basically, there are two types of hypertension: primary, which is or idiopathic or essential, and secondary hypertension. We know primary or idiopathic hypertension is essentially driven by lifestyle changes, and it constitutes about 95% of all hypertensives. Only 5% of patients have secondary hypertension, which means that 95 that this essential or this term used is primary hypertension. Previously, the term essential hypertension was used, and essential hypertension means that their blood pressure, when the concept was that the blood pressure essentially rises with age, and we now know that this is not physiological and not necessary, and therefore the term essential should be dropped. Similarly, the term idiopathic hypertension should also be dropped. Why? Because at this point of time, we really do not know what the exact cause of essential of primary hypertension is, and therefore, but in future we will know the cause, and therefore the term which is most commonly accepted is primary hypertension, which is constitutes more than 95% of all hypertensives. And this is basically a lifestyle disease where it is driven by adopting risky behaviors like a lack of physical activity, obesity, and I'll talk to that later. These are the risk factors for hypertension. So primary hypertension is basically treatable but not curable, and once a hypertensive needs to be treated lifelong. Primary hypertension, so it's treatable. We can bring down the blood pressure to normal by giving drugs or lifestyle modification, but it's not curable, and therefore it is lifelong. Secondary hypertension actually constitutes about 5% of all patients who have hypertension, and there is a specific cause for secondary hypertension, and if that cause is removed, the patient is totally cured of his hypertension. So secondary hypertension is curable, primary hypertension is treatable but not curable. So what are the risk factors for primary hypertension? So since we do not know the exact cause of primary hypertension at the molecular level, we talk of risk factors which precipitate high blood pressure. The most important is excessive salt intake, that is 12 grams per day. What is happening is that we are consuming a lot of excessive salt, and now which is much more than what our ancestors ate. The physiological requirement of salt is about 5 to 6 grams, and we are consuming exactly the double of what the body requires. And why people consume so much of salt is because it makes the food tasty. But it's a very important factor which can precipitate hypertension. Sedentary lifestyle, that means patients do not exercise because of motorization, and people using cars and scooters for travel and doing office work sitting down, that is sedentary lifestyle. And lack of physical activity, no leisure time physical activity done by majority of people, which can lead to hypertension. Which can lead to obesity. Obesity could be generalized or it could be abdominal obesity, and generalized obesity is measured by body mass index, where we divide the weight in kilograms divided by height in meters square. Up to 25 is considered normal. Abdominal obesity is measured by waist circumference and divided by the hip circumference. Waist circumference in Western population should be more than 102 centimeters. In the Indian populations, in males, it is 102 in males, and in females it is 88 centimeters as per the WHO criteria. But South Asia specific guidelines are different. In South Asia specific guidelines, the waist circumference more than 90 centimeters in males and 80 centimeters in females is considered to be abdominal obesity is present. So this leads to obesity is basically because of consumption of excessive calories and high fatty food which are rich in calories. Lack of intake of fruits and vegetables, because fruits and vegetables contain lots of salt, lots of potassium, which is an antagonist to salt, and it contains lots of fiber and also a lot of antioxidant vitamins. And because of this, a lot of intake of fruits and vegetables is considered to be protective for hypertension, diabetes, as well as for cardiovascular disease. And because we are consuming less salt and we are consuming less amount of fruits and vegetables, which can precipitate high blood pressure. Psychosocial stress is an important factor which causes risk factor for development of hypertension. In our intra-heart study, we measured 4 or 5 types of stress: the stress at work, stress at home, stress at financial stress, and stress and adverse life event score, like death of a close family member. So all this psychosocial stress, actually, we are living in an area in urbanized population where psychosocial stress has increased. History of alcohol intake, again, is an important factor for causing hypertension. So these are risk factors for development of hypertension, which has led to an increased prevalence and incidence of hypertension over the past few decades in India. Whereas secondary hypertension is basically certain problems diseases can cause hypertension. For most common is renal parenchymal disease, that is chronic kidney disease, can lead to hypertension, because it will prevent the excretion of salt and water in the urine and will lead to edema feet, and that can cause hypertension. Then renovascular hypertension, that means whenever there is a renal artery stenosis, that will activate the RAS system, that is renin angiotensin aldosterone system, and when aldosterone is being activated, secreted, it will cause salt and water. It's a mineralocorticoid which causes salt and water retention by acting on the zona glomerulosa of the adrenal medulla. So renovascular hypertension because of renal artery stenosis can cause secondary hypertension. Primary hyperaldosteronism, that means Conn's disease, which is usually because of an adenoma in the adrenal cortex in the zona glomerulosa, can also lead to high blood pressure, because aldosterone will cause salt retention and will cause potassium loss. Obstructive sleep apnea is emerging as an important cause of secondary hypertension, where patients who are obese can develop obstructive sleep apnea and difficulty in breathing, apneic smells in the night when they sleep, and they snore a lot. And during that period, that causes hypoxia and hypercapnia, and that can stimulate the respiratory center and also is an important cause of secondary hypertension. Certain drugs, like use of non-steroidal anti-inflammatory drugs, alcohol, can cause increase in blood pressure and can cause hypertension. Other endocrine causes also are important causes of secondary hypertension. Pheochromocytoma, where the patient presents with, it's a tumor of the adrenal medulla, where where that tumor actually secretes a lot of sympathomimetic amines, and the patient presents with palpitations, headache. And Cushing syndrome, which is a tumor of the adrenal medulla cortex in the mid zone, zona fasciculata, which secretes corticosteroids, and also it could be because of pituitary gland, and that causes hypertension. Thyroid abnormalities like hypothyroidism, and as well as hypothyroidism causes increase in diastolic blood pressure, whereas hyperthyroidism causes increase in systolic blood pressure. Coarctation of aorta is an important cause of hypertension, especially in children, and where you can find that the blood pressure in the upper limb is markedly elevated. But if you see the palpate the pulsations in the lower limb, the femoral artery or the popliteal artery or the posterior tibial artery or the dorsalis pedis, they are weak. And if you take the blood pressure in the lower limb, the blood pressure would be low, but blood pressure would be very high in the upper limbs. A feature of coarctation of aorta, which should be detected and treated, otherwise the patients can develop complications of hypertension. Then primary hyperparathyroidism also causes secondary hypertension. Congenital adrenal hyperplasia, mineralocorticoid excess syndromes, acromegaly, these are some rare causes of secondary hypertension. The point I'm trying to drive is that there are number of causes of secondary hypertension, but they constitute only 5% of total hypertensives. And if you remove the cause and treat the secondary hypertension, it is totally curable. There are certain clues while examining a patient to know whether the patient has primary or secondary hypertension. For example, if a blood pressure, usually secondary hypertension would occur in below the age of 30 or after the age of 55. And patient, you should always ask history of family, personal or family history of any kidney problem, disease. And if a patient presents with episodic headache, palpitation, sweating, and paroxysmal hypertension, is a feature of pheochromocytoma. And if the patient has developed central obesity, facial rounding, or puff, or and redness, easy skin bruising, or patient has diabetes and muscle weakness, this is features of Cushing's syndrome. And if a patient has hypertension and hypokalemia as a feature of primary hyperaldosteronism, and if a patient presents with spontaneous bone fractures, kidney stones, anorexia, or abdominal pain, and psychiatric disturbances are a feature of hyperparathyroidism, which can cause high blood pressure. So, clinical clues of secondary hypertension would be uncontrolled or resistance. Blood pressure was initially controlled and subsequently has uncontrolled or resistant hypertension. One should always search for a cause of secondary hypertension. Examination of pulses is very important. If you find that the pulsations in the lower limbs are weak and the pulsations in the upper limb are okay, are bounding, that is a sign of a coarctation of aorta. And if you find that the pulsations in the upper limb are weak and the pulsations in the lower limb are bounding, and if you take the blood pressure in the upper limb, it is normal or it is slightly on the lower side, but blood pressure in the lower limb is very high, that is a sign of aortoarteritis or Takayasu syndrome, which basically affects the ascending aorta and the arch of the aorta. And we know from the arch of the aorta, the major great vessels which supply the brain arise. And the first branch is the innominate artery or the brachiocephalic artery. The second branch, major great vessel, which arises from the arch of the aorta, is the left common carotid. And the third is the left subclavian. The origin of these vessels can get osteal stenosis can occur of these origin of these vessels because of aortoarteritis, which heals by fibrosis, and this might lead to decreased blood flow in the upper limbs, and the upper limbs the blood pressure may drop, and the pulsations in the upper limb would be weak, but the blood pressure in the lower limb would be more increased, and also it might lead to osteal narrowing of the renal artery, and that can again lead to hypertension in the lower limb. So examination of pulsations therefore is very important. And on an examination of the abdomen, there could be a renal artery bruit heard, which would indicate that the patient has renal artery stenosis. Or if the kidneys are palpable or ballotable, that is a sign of polycystic kidney disease, which again can lead to hypertension. So these are some clues on history or on examination which will tell you that the patient has secondary hypertension. It's very important to search for them so that we can cure the hypertension if this cause is removed. So screening for secondary hypertension is new onset uncontrolled hypertension in adults, drug induced abrupt onset of hypertension less than 30 years, exacerbation of previously controlled hypertension. Because what happens in elderly also is that if the blood pressure is fairly controlled and then the controlled blood comes on, the patient's blood pressure is not being controlled, it could be possible that there is a athermatous plaque which is causing narrowing of the renal artery, and that might lead to renal artery stenosis, which can cause resistant hypertension. That should be searched for, especially in elderly people. And onset of diastolic hypertension. So these are some of the ways in which we can diagnose or secondary hypertension. I have elucidated that in quite detail. So this accelerating epidemic, I have already told that the heart attacks are increasing, and this is essentially driven by unhealthy lifestyles. Look at the children playing in the grounds and eating a traditional diet previously. Now people play computer games and consume a diet which is Pepsi and other things, a phenomenon called Coco-colonization and McDonaldization, which is occurring in our children, and the use of mobile phones and mobile games, which is much more common than playing outdoor games. And therefore, these lifestyle-driven diseases like hypertension, diabetes are increasing. This is our study which was conducted in 52 countries, more than 15,000 cases of heart attacks, and a study published in Journal of American Medical Association, quoted by nearly 1,500 people till date in the PubMed. And hypertension is a very important risk factor, one of the 9 risk factors which are associated with heart attacks. And in fact, for stroke, hypertension is the most important risk factors, and this has been demonstrated by a number of studies like the InterStroke study. Now, it has been always thought that hypertension is a disease which occurs in elite people. But the studies have clearly shown that poor people, uneducated people, hypertension, diabetes, and dyslipidemia remains undetected, untreated, and uncontrolled. We know that people who live in the slums and who are from the lower socioeconomic strata or from the rural population, they do not go to because hypertension is essentially asymptomatic disease. The people do not go to get their blood pressure checked, and therefore there is a rule of half. That means that is in Western countries, but in India, it is a rule. I'll come to that subsequently. So we've already shown that educational status, in fact, inversely related to the risk of hypertension, as well as this. Obesity, again, is quite common in urban areas. Psychosocial stress is very important, and that leads to, because of a lot of external stress, with patients who are under psychosocial stress actually do not consume their medications properly, do not adopt a healthy lifestyle, and they may smoke, consume a very fatty diet, consume alcohol, do not do any physical activity, and do not take their medications, and that might lead to high blood pressure. Physical activity in our Indian population is quite low. In fact, our study showed actually that more than 90% had no recreational physical activity. Now, this is important study, which was the INDIAP study where we participated, where an ICMR funded study, which actually showed that majority of hypertension, especially in the rural population, remains undetected, untreated, and uncontrolled. The rules of halves, which I was talking about in the Western population, about 50% of hypertensives are undetected. Of those 50% who are detected are untreated. Of those 50% who are treated, only 50% are controlled. In India, this is much more dismal. If you see this slide in Maharashtra, you will see that about 80% are undetected, are detected for the first time during the survey of that they had hypertension. And a majority of these people are not taking medications, and majority of them are not controlled. So in India, the rule of half is this, it's a rule of 3/4. 3/4 of the hypertensives are undetected, 3/4 are untreated, and 3/4 are basically uncontrolled. So this problem of undetected, untreated, and uncontrolled indicates that hypertension awareness as measure of the ratio of known to newly detected hypertensive remains particularly low, especially in rural areas. More than 2/3 hypertensives are undetected, and therefore there is absolutely a need for health education, and more screening is needed. So accurate measurement of blood pressure is very important. And there are for diagnosis and management of high blood pressure, proper methods are recommended for accurate measurement and documentation of blood pressure, so that we do not have erroneous readings. And the appropriate technique of office blood pressure is important. Position of the patient should be seated. The selection of cuff size, which should cover about 2/3 of the arm. And there should be proper calibration. Calibrated instrument should be there. Training should be there. Multiple measurements should be done. If there measurements of blood pressure is in the one limb is taken out, and second reading taken, if there is a difference, then that third reading has to be taken. So this will reduce what is known as white coat hypertension, and I'll come to that later on. How to measure blood pressure is very important, and I'll emphasize this again, that we have to use a machine which has been validated, well maintained, and properly calibrated. Patient, usually we have to take the blood pressure in sitting position and remove any tight clothing. We see many times blood pressure being taken over the cloth, over the arm. That should not be done. It should be taken on a bare arm. We should have the arms at the level of the heart. Use a cuff which is appropriate size. It should cover at least 2/3 of the arm. Lower the blood pressure slowly and take 2 measurements with each visit. Usually we take blood pressure in both standing as well as sitting position, and also sleeping position. There is a problem of orthostatic hypotension. When the blood pressure is taken in the recumbent position, the blood pressure may be normal, but as soon as the patient becomes upright and you take the blood pressure in standing position, the blood pressure drops. And this is a feature of hypostatic hypotension, which is a orthostatic hypotension, in fact, is occurs basically in patients who have autonomic failure, which is a feature of elderly people, and therefore and patients who have diabetes, and or patients who have postural hypotension or symptoms about it. It is important to take blood pressure in recumbent as well as in standing position in these patients also. And there is and we need to do once hypertension is diagnosed, we need to do ambulatory blood pressure monitoring and home monitoring blood pressure, especially in patients who have white coat hypertension. Normally, we do not take blood pressure in the lower limb, but there are specific indications when blood pressure has to be taken in the lower limbs. One is when the pulsations in the lower limb are weak, and this occurs in coarctation. Blood pressure has to be taken in the lower limb in coarctation of aorta, or in reversed coarctation, or in what is known as aorta arteritis, where the pulsations in the upper limb are weak, but the blood pressure pulsations in the lower limb are bounding. In that occurs in patients who have aortoarteritis or reverse coarctation. Blood pressure needs to be taken in lower limb. Or if a patient has a collapsing pulse, and which is seen in aortic incompetence, we need to take blood pressure in the lower limbs also, because there is a sign called Hill sign, which when the systolic blood pressure difference in the lower limb and the upper limb is more than 20 millimeters of mercury, is a sign of aortic incompetence, which is called the Hill sign. So there are certain indications when blood pressure has to be taken in the lower limb. Now, what is the role of ambulatory blood pressure monitoring or home blood pressure monitoring? Now, this is coming out in a big way. Ambulatory blood pressure machine is there. We have to ask the patient to tie it, and then this blood pressure inflates and takes the blood pressure, and deflates and takes the blood pressure every half to 1 hour. In 24-hour record, therefore, is available with us, and it can be monitored, and we will know what is the circadian rhythm and when the blood pressure is normal, when the blood pressure is high, because minute to minute and variations of blood pressure are quite common. When do we use this? And home monitoring is that we give the BP apparatus, electronic devices, which digital devices, where the patient is asked to take the blood pressure every hour in his home. That is home monitoring of blood pressure. This is particularly important to detect white coat hypertension or clinic hypertension. Now, what is white coat hypertension or clinic hypertension? It is that the blood pressure is elevated only in clinic setting. That means in the office, or if the patient comes to in the hospital and takes the blood pressure, he is already very anxious and his sympathetic activity is more, and the blood pressure recorded in the hospital or in the clinic is high. Whereas if the same blood, and also he is afraid of the doctor with a white coat which is wearing, and therefore it is called the white coat hypertension or the clinic hypertension. And the same blood pressure which is taken at home by a nurse or a less formidable person, or by himself, and in a more familiar circumstances, the blood pressure may be normal. This is known as white coat hypertension, and this we can confirm it by doing what is known as home monitoring of blood pressure or ambulatory blood pressure of monitoring. The exactly opposite of office hypertension or white coat hypertension is what is known as masked hypertension. That is where the blood pressure is normal when he comes to a doctor, and when the doctor takes the blood pressure in the clinic, and the blood pressure becomes elevated in the evening, in the night, or in the home when the blood pressure is taken. This is known as masked hypertension, because the blood pressure recorded by doctor is normal, but when he goes home, probably because of some circumstances, because of in the house which are very irritating, the patient's blood pressure may be elevated in the house, but may be normal in the clinic, because when he comes to the clinic, he may feel secured, and his hand calms down, and his blood pressure may normal. This is called masked hypertension, and therefore a discrepancy of more than 20 systolic and 10 millimeters diastolic between clinic and average daytime in ambulatory blood pressure monitoring or home blood pressure monitoring, we can diagnose what is known as masked hypertension. So these two terms of clinic hypertension or white coat hypertension and masked hypertension are important and should be remembered. Then for diagnosing hypertension, if the blood pressure is more than 140 by 90 millimeters of mercury, you have to generally take a third reading and average them out and record the lower of the last two readings as the clinic blood pressure. If the blood pressure is between 140, 90 and 180, 120, then we patients ideally should be offered ambulatory blood pressure monitoring to confirm the diagnosis of hypertension, so that we eliminate the errors which can occur because of masked hypertension or which can occur because of white coat hypertension. We can skip this slide. Now, another important feature is nocturnal blood pressure dipping. Normally, when a person sleeps, the blood pressure drops by about 10 to 20% during sleep, and therefore 24. And as soon as the person gets up in the morning, there is a morning surge of blood pressure. This is the normal circadian rhythm of blood pressure. Blood pressure drops when the person sleeps comfortably and to nearly by 10 to 20%. But when he gets up and starts walking, the blood pressure, there is a morning surge. This is the circadian rhythm which is normal. Now, there are certain people whose blood pressure do not dip, and that non-dippers, that is blood pressure in the night does not dip less than 10%, and that this is an important association with cardiovascular risk. So the blood pressure may be normal, but there is a non-dipper. The blood pressure does not drop in the night. That is also associated with cardiovascular morbidity attributable to high blood pressure. So there are non-dipping and cardiovascular outcome. Number of studies have shown that persons whose blood pressure does not dip in the night actually is associated with heart attacks and heart failure, stroke, sudden deaths, target organ damage, increase in carotid intima media thickness, and left ventricular hypertrophy. And therefore, it is important to monitor 24 hours by doing what is known as ambulatory blood pressure monitoring and home monitoring, which can help to detect non-drippers. This is an important guideline, and we can go through this subsequently. So how do you diagnose and how do you work up, and what investigations you do once you detect that the patient has hypertension? There are three things which we need to do. First is we have to assess the risk factors of hypertension. We know hypertension is an asymptomatic disease. We do not treat the patient because he has hypertension to treat the symptoms of hypertension. But basically, we want to treat the hypertension so that he does not develop cardiovascular complications of hypertension, which can, in the long term, if the hypertension remains undetected and treated, it can lead to cardiovascular complications. And therefore, other risk factors apart from hypertension have to be assessed. Now, these other risk factors which I have just mentioned in the Enter-Heart study, we have to ask a detailed risk factor profile of a person who has hypertension is important, because we want to know what is the risk of this person at the end of 10 years going to develop heart attacks or paralytic strokes. And we have to take a detailed history of diabetes or investigate diabetes, then lack of intake of fruits and vegetables, tobacco intake, smoked or non-smoked form, cigarette smoking or BD smoking, then abdominal obesity, lack of physical activity, psychosocial stress. All these things have to be assessed in detail. So associated risk factors are very important, which determine how aggressively we treat hypertension. And then we also need to find out how severe the hypertension has been by looking at what is the target organ damage or end organ damage which has occurred because of high blood pressure. We know that because of high blood pressure, a lot of changes occur in the blood vessels. When the blood vessels are exposed to high blood pressures, it leads to changes like intimal hyperplasia, or it leads to endothelial hypertrophy, medial hypertrophy, and it leads to fibrinoid necrosis and segmental lipohyalurosis, which are the pathological changes which occur in blood vessels when a person is exposed to high blood pressure for a long time. We have to conduct so three things are important. First is the assessment, complete assessment of the risk factor profile of a person, and second is the full assessment of the target organ damage or the complications of hypertension which the patient has. We have to ask a detailed history and do a detailed physical examination, and certain lab investigation like urine analysis, blood sugar, lipid profile, hematocrit, sodium, potassium, creatinine, calcium, and these are always, and urinary albumin creatinine ratio, ECG are usually, and also an echocardiogram are usually done in patients who have hypertension. We have to identify the cause of, identify a treatable cause for hypertension. C for sleep apnea, which can occur in patients who have obstructive sleep apnea, where the patient is obese and snores a lot. Whether certain drugs are there which can cause hypertension, like non-steroidal anti-inflammatory drugs actually cause salt and water retention, and steroids also cause a rise of blood pressure. We see whether the patient has any evidence of chronic kidney disease or primary hyperaldosteronism or renovascular disease or Cushing's syndrome, pheochromocytoma, coarctation, and thyroid profile. These are some indications, investigations and identification has to be done. Now, what are the complications of hypertension? Thank you very much. I'll discuss the complications in the next talk. Thank you very much.